Hello and welcome to my channel. So the next important topic that I am taking today is Wilm's tumor. Wilm's tumor is also known as nephroblastoma, and this topic is important for the theory, practical, as well as many MCQs come from this topic in the PG entrance exam. So Wilm's tumor, it is most common primary renal tumor seen in the childhood. The common age group where it is seen, it is 2 to 5 years of age, and majority of the cases, about 90 to 95% of the cases, they are sporadic, but in 5 to 10% cases we can see various germline mutations, and those mutations they are traced to the epigenetic and genetic alterations in chromosome number 11p, that is short form of chromosome 11. And because of those mutations, there are three groups of congenital malformations that are seen commonly associated with Wilm's tumor. Now these three groups of malformations, this you should know, very commonly asked in the entrance exams. So first is the Vigor syndrome. Now Vigor syndrome, it stands for, W stands for Wilm's tumor, A for aniridia, G stands for genital anomalies, and R for mental retardation. Now earlier it was called mental retardation, but now we call it intellectual disability. So we don't use the term mental retardation anymore, we call it intellectual disability. So these four components, they come in the Vigor syndrome, and the Vigor syndrome is associated with mutations and which are traced to chromosome 11p 13. So this is the locus, and this locus harbors the two genes, that is WT1 gene and the aniridia gene or the PAX6 gene. So mutations are seen in these genes, and because the WT1 gene, this gene codes for a protein, WT1 protein, and that is important in the development of the kidney as well as the gonads. So when there is mutations, and it causes this Vigor syndrome. So you should remember this gene locus and this tetrad of symptoms. And in the Vigor syndrome, there is a 33% lifetime risk of developing the Wilm's tumor. So this is the first, Vigor syndrome. Now the next syndrome is Dennis-Drash syndrome. Now this syndrome is associated with missense mutations in the same gene, that is WT1 gene, and the lifetime risk for Wilm's tumor is more than that in Vigor syndrome, that is 90% increased risk, and there is also increased risk for gonadoblastoma. So gonadoblastoma is a tumor consisting of germ cells and sex cord stromal cells and seen in the gonads. Now Dennis-Drash syndrome, it manifests with gonadal dysgenesis, male pseudohermaphroditism, and nephropathy. So kidney shows diffuse mesangial sclerosis and later on develops into renal failure with development of the Wilm's tumor. So this is the second syndrome that you should remember. It is associated with Wilm's tumor, and the gene showing the missense mutation is again the WT1 gene. Now next is Beckwith-Whitman syndrome. So in this syndrome, the gene that is showing the mutation is the WT2 gene. Now previously the two syndromes, they were associated with mutations in WT1 gene, that was in 11p13 locus, and this third syndrome, it is with associated with WT2 gene, and the locus is 11p15. Now in this syndrome, what happens, that there is the loss of imprinting. So the WT2 gene, these alleles, they are inherited in both the maternal and paternal chromosomes. So normally what happens, this maternal gene, it is imprinted, so it is not expressed. But when there is loss of imprinting on the maternal allele, then what happens, the insulin-like growth factor, it is overexpressed because of the loss of imprinting. So this results in increased proliferation and the development of Wilm's tumor. So patients also have the enlarged body organs. Adrenal cytomegalomy means increase in the size of cells, which is abnormal in the adrenal glands. Then renal medullary cyst, Wilm's tumor is the association. Then organomegaly, hemihypertrophy, enlarged tongue, that is macroglossia, and omphaloceal. that is umbilical hernia. So all these things, they can be seen with Whitman syndrome. You need to remember that the gene involved here is WT2 gene, and the defect is in the imprinting. There is loss of imprinting, and the various symptoms that you should remember. So these were the three syndromes. So these were the three syndromes that are associated with Wilm's tumor, and you have to remember all these syndromes for the viva as well as the entrance exams. Now in the sporadic cases also mutations are seen. The mutations of beta catenin gene and the mutations which are involved in the genes involved in microRNA processing, like DROSHA, then dicer1, DGCR8 gene. So these genes are mutated in the sporadic cases. So the sporadic cases, they are more than the familial cases. Now we come to the clinical features. So most commonly it presents with the abdominal mass which is palpable and mostly reported by the parents of the child, and other symptoms can be hematuria, pain, fever, hypertension. So most importantly in the problem based question also you will find this symptom most consistent, which is palpable abdominal mass in a young child. Now we come to the important aspect, that is morphology of the Wilm's tumor. So in the kidney we will see a large solitary well circumscribed mass. Let me show you here. So there is a in the kidney, this is the kidney, this is the cortex part and medulla, and here you can see that the kidney is replaced by this mass which is grossly having an appearance of a soft So we will try to understand the gross morphology with this image. So this is a kidney and this is the kidney. The outline is distorted by this tumor. This is the tumor. This part is the cortex and medulla, and here it is replaced by this large tumor which is present in the lower pole of the kidney. The cut surface is showing a bulging appearance and it is homogeneous with focal areas of hemorrhages, and consistency is soft in Wilm's tumor, and the tumor is generally large and it is unilateral, single and well circumscribed. So this is the gross appearance. So if you have to draw this tumor in the exam, so you just draw the normal kidney and thus replace the kidney tissue by this large round well circumscribed mass having tan to grey appearance and focal areas of hemorrhages. Next in the microscopy, so in the microscopy there is triphasic histology. So you have to remember that it is triphasic in appearance. So mainly three components are seen. First is epithelial component, second is blastemal component, and third is the stromal component. So primitive looking cells are seen in the blastemal component. That these cells, they are arranged in the form of sheets, tubules, cords. In the epithelial components, these cells, they are forming abortive tubules and glomerular-like structures, and in the stromal component mainly spindle cells, they are seen along with a myxoid stroma. So let us understand with these images. So this is an image of Wilm's tumor, and we can see these round blue cells which are seen here. So these cells, they are dark blue in color, rounded and having a very scanty cytoplasm. So these cells, they are arranged in the form of sheets, tubules in the blastemal component. So all this is the blastemal part. These are the blastemal part. And along with that there is the epithelial component. In the epithelial component we can see this tubule-like structures. So this is a tubule. They are called abortive tubules. So there is attempt of formation of the tubules. So these are the tubules, and then some structures like the glomerular structures, they are also seen like this. In this picture we can see this is the structure looking like a glomeruli, because you know that when you talk about the glomeruli, there is a glomeruli in the outer parietal epithelium, And the visceral epithelium and the tuft of capillaries, it is seen in here. So there is a Bowman space here. So by this we recognize the glomeruli. So this is a Bowman space, and this is a tuft of glomeruli. This is the outer epithelium parietal. So and these are the tubules. Normal. This is the normal kidney. Again, this is the glomeruli, normal glomeruli, and these are the normal tubules. But in Wilm's tumor, we see the abortive tubules and abortive glomeruli. So these are the tubules. These are the cells of the Wilm's tumor which are trying to form a tubular structure here. So there is a tubular structure, and sometimes they form a rosette-like structure, and they also try to form glomeruli-like structures. So these are the glomeruli-like structures. Here you can see this is the empty space, and these the cells in the center, and there is the outer epithelium. So they look like glomeruli, but they are not true glomeruli. So they are known as abortive glomeruli. So they attempt a formation of structures which are similar to the glomeruli and the tubules. So these two structures, they form the epithelial component of the Wilm's tumor. And the third component is the stromal component, which is the mesenchyme. So it is composed of the spindle shaped cells and myxoid areas. So this is all the connective tissue stroma, and sometimes this stroma can show the heterologous elements like cartilage, fat, skeletal muscle. These can be seen in the stroma. Another thing is the nephrogenic rest. So nephrogenic rest is the primitive kidney tissue, the metanephric tissue, and the tumor is supposed to arise from this nephrogenic rest. So these are the precursor cells. So they will be seen adjacent to the tumor. So another important point is that anaplesia. So anaplesia it is seen in a minority of cases of Wilm's tumor, and if we see anaplesia in the microscopy, then we have to put it down in the report, because anaplesia is a bad prognostic feature and it is associated with resistance to chemotherapy. So in the anaplastic variant, we will see the pleomorphic hyperchromatic cells, and there will be presence of increased abnormal mitosis. So this was all about the microscopy of Wilm's tumor. So you need to remember this triphasic histology: epithelial element, blastemal and stromal components. And this is again the gross picture. The tumor seen at the pole, having a homogeneous appearance, generally soft in consistency. It is well circumscribed. Again here also this is a tumor, and this is the normal kidney parenchyma. This is a microscopy showing the tubular structures. This is the tubular element, epithelial element forming the tubules, and this all is the blastemal component. Also, one more important point, that the important immunohistochemical marker for Wilm's tumor is WT1. Now, anaplesia in the Wilm's tumor, an important point is it is associated with p53 mutation, and I have already told you that it is associated with the bad prognosis. So this is all about Wilm's tumor. Now the histology of Wilm's tumor I will teach in the next lecture. The microscopy of Wilm's tumor is also important for the exams. If the question comes, then you have to draw this. So this I will explain in the next lecture. Thank you very much. If you find this video useful, then please like and share it and subscribe to my channel. And feedback is most welcome in the comment section. Thank you very much.